Welcome, everyone. Thank you for joining us for today's webcast, Copay Accumulators, Striking a Balance Between Promoting a Healthy Workforce and Managing Costs, sponsored by Aimed Alliance. This webcast has been pre-approved for HRCI and SHRM credit. Please be sure to attend the complete webcast in order to receive your credits. If you have any questions during the webcast, click on the Q&A tab in your webinar controls and type them there. I'll post a link to the exit survey in the chat area once the presentation is started, and a new tab will open in your browser with the webcast survey also. So please be sure to complete it as soon as the webcast is ended. It is now my pleasure to turn it over to Stacy Worthy for a brief introduction of today's speakers.
Thank you, Hester. So good afternoon, everyone, and welcome to today's webinar on Copay Accumulators. We're offering this webinar to explain the impact of Copay Accumulators on both employers and employees or the patient. I'm Stacy Worthy. I'm counsel to Aimed Alliance, and today we're joined by Rick Fry, Vice President of Client Services at TrialCard, Dr. Bruce Sherman, the Medical Director of the National Alliance of Healthcare Purchaser Coalitions, and John Wylam, Staff Attorney for Aimed Alliance. So with that, I'm going to turn it over to John.
Hello, everyone. So before I begin my presentation, I can give you some details about my organization, Aimed Alliance. Aimed Alliance is a nonprofit health policy organization. Our mission is to protect and enhance the rights of healthcare consumers and providers. And we envision a society in which consumers can make their own decisions about their own healthcare without having those decisions overridden by third parties. This means that we stand up for consumers whenever they're prescribed a treatment or service and they have trouble accessing those treatments or services because of barriers erected by other healthcare stakeholders. And one such barrier is a copay accumulator, which we'll be discussing today. Here's a rundown of today's agenda. First, we'll provide an overview of copay accumulators, what they are and how they function. Next, we'll discuss the legal, legislative, and regulatory landscape of copay accumulators, including a look at both state and federal law. Then we'll discuss how copay accumulator programs impact patients and employees. And after that, we'll talk about affordability issues and how copay accumulators can create real-world issues for patients. We'll conclude with a Q&A so we can answer any of your questions. So let's get started. A copay accumulator is a policy included in a health plan that excludes the value of a third-party financial assistance from an enrollee's deductible or maximum out-of-pocket limit. So that means that if you were to go to a pharmacy and fill a prescription using financial assistance from another person or organization, that money won't count towards your deductible or out-of-pocket limit, subject to the terms of the accumulator policy. The deductible is an important number because once enrollees reach their deductible, their cost-sharing responsibilities are minimal. And historically, the value of third-party assistance has been counted towards the deductible and out-of-pocket limit. So copay accumulators are a new policy that reverses that trend. These policies result in patients incurring out-of-pocket costs that exceed their deductible in many instances. Next slide, please. All right. So copay accumulator policies are becoming increasingly popular among employers and health plans, but why? Well, patients often rely on third-party financial assistance from pharmaceutical manufacturers when they're purchasing their prescription drugs. This often takes the form of copay cards that have a set dollar limit, which patients can use to cover their cost-sharing responsibilities when buying that manufacturer's product. The costs of prescription drugs are continuing to rise, so patients increasingly rely on this type of assistance to be able to afford their medication. Copay assistance is especially important for people with chronic conditions who need to take very expensive medications regularly to maintain their health and everyday functioning. So this arrangement could result in patients using copay assistance to pay for expensive medications early in the year, which would fulfill their deductible, and then seeking more expensive medical services afterwards at minimal cost to themselves. And health plans don't really like that because it causes them to lose money. As I mentioned earlier, health plans cover a greater share of healthcare costs after a patient reaches their deductible. So copay accumulators exclude third-party financial assistance from the calculation of the deductible, which forces the patient to use only their own money to satisfy their deductible. So we went from a situation where health plans were losing money because of third-party financial assistance that was used to satisfy the deductible to patients getting stuck with the bill. On that topic, some copay assistance has a set dollar amount. So if an enrollee exhausts that money and they still haven't reached their deductible, they could suddenly be unable to afford their medications because the copay or coinsurance is too high. Enrollees generally lack awareness of copay accumulator policies, so they are often surprised to find out that they haven't reached their deductible. Some enrollees would plan their healthcare utilization around reaching their deductible, and copay accumulators can cause their plans to go awry. Next slide, please. While enrollees are generally unaware of these policies, it doesn't help when health plans use misleading or confusing language. Some plans use language that would suggest that the copay accumulator program is working to the enrollee's benefit when it's not. An example of this is copay adjustment, benefit plan protection program. The words benefit and protection here are misleading to enrollees. And on this slide, we have some language that a health plan used to describe their copay accumulator program. This language is pretty confusing if you're not already familiar with how health insurance and third-party financial assistance works. And there have been some times when the existence of a copay accumulator program isn't disclosed to enrollees at all. So we have a situation where enrollees either don't know about the program or they're misled to believe that it's a benefit when it's not. So why would an employer want to implement a copay accumulator program in their health benefit? Well, they could want to shift some costs to their employees to ensure that they have more skin in the game and to get them to be more invested in their health and healthcare. However, this relies on the assumption that healthcare consumers are rational consumers and that they have all the information that they need to make informed decisions. But that's simply not always the case. I think we can all attest to how confusing healthcare can be and how we don't always get to choose when we go to the doctor or hospital. Sometimes, despite our best efforts, we get sick. This also assumes that effective substitutes exist for every treatment. However, for many conditions, there is only one very expensive option for them, and they don't have alternatives. Imposing a copay accumulator on a patient like that is simply punishing them for getting sick or for having a certain condition. In fact, a recent study found that more than 50% of the medications that have copay assistance available to them have no generic substitute or only have similarly priced equivalents. Another consideration for employers is their bottom line. They don't want to lose money when their employees use third-party financial assistance. However, when these policies are imposed, they can result in direct and indirect costs that could cost the employer even more money in the long run. On this slide, we've got some examples of those potential direct costs to employers. Like I mentioned before, if a patient exhausts their financial assistance and they suddenly can't afford their medication without reaching their deductible, they may have to abandon treatment. And if not treatment abandonment, they may have to ration out their medications or switch medications. And all of these options aren't ideal from an effective treatment standpoint. Non-adherence, treatment abandonment, and medication switching can all result in disease progression or relapse. And that can lead to the patient needing to go to the doctor more often or even hospitalization. And those things drive increased healthcare utilization, and that's going to cost the patient and the employer. So these are all consequences that can be avoided by making sure that patients have uninterrupted access to the treatments that are prescribed to them. Treatment non-adherence and abandonment can also result in lower productivity, which wastes resources. And this can also result in absenteeism, with employees taking more sick days to try to feel better while their health goes unmanaged. If things get really bad, employees may rely on a disability policy to cover their expenses while they miss work because of their unmanaged health condition. So in response to the rise of these policies and to protect patients, 4 states have enacted laws that regulate copay accumulator programs, and this includes Arizona, Illinois, Virginia, and West Virginia. If you're a large employer, you likely won't be regulated by these laws because your health plan will be subject to federal law instead. But if you're a small employer that has your employees purchase health coverage on the health insurance marketplace, these laws could affect your employees. So I'll review some differences between these laws now. So to start with Virginia, we think that their copay accumulator law is the strongest. This law requires health plans to include in the calculation of any of the plan's cost sharing requirements any amount paid by the enrollee or on behalf of the enrollee. So this applies only to health plans and not pharmacy benefit managers, and it applies to all healthcare services, not just prescription drugs. West Virginia's law functions the same as Virginia's law, but it also does apply to pharmacy benefit managers. So those two are very similar. Illinois also is similar, but it limits the application to prescription drugs and doesn't include medical services. The one outlier here is Arizona. Their law is slightly different. This law applies to health insurers and pharmacy benefit managers, but it only applies to prescription drugs. The law requires health plans and pharmacy benefit managers to include in the calculation of any of the plan's cost-sharing requirements any amounts paid by the enrollee or on behalf of the enrollee. So that part is the same as Virginia's law, but the law will only apply if the enrollee fills a prescription for a medication that doesn't have a generic equivalent. Alternatively, it would apply to a medication with a generic equivalent, but only after the enrollee gains access to it after going through utilization management, such as step therapy. So this law does strike a bit of a balance, and you can see how it encourages enrollees to pursue lower cost options when there's a generic available. But if there isn't a generic available, it's not going to punish them. So that will incorporate those cost sharing amounts in that case. So all of these laws regulate amounts paid by any third party, which means that they're not just limited to financial assistance from pharmaceutical manufacturers. And all 4 of these laws were enacted recently, so we're expecting to see additional laws passed in 2020 in the states. So next, we'll be hearing from Stacey Worthy about some legal issues that affect copay accumulator programs.
Thanks, John. Yes, I want to go over quickly recent regulatory developments. So back in April, CMS issued the Notice of Benefit and Payment Parameter for 2020. And this is a rule that allows copay accumulators in instances, only in instances where there's both a generic and brand product. Otherwise, they're prohibited. And it would have also allowed for an exception request if a patient needed a brand medication, although a generic is available, if that medication is medically necessary. And it would have deemed the denial to be an adverse benefit determination, which would be right for appeal. This applied to all plans offering essential health benefits, including employer-sponsored plans that voluntarily opt to offer EHBs. However, in August, the Department of Health and Human Services, Department of Labor, and Treasury issued an FAQ in which they announced that they weren't going to be enforcing this provision of the MBPP that applied to copay accumulators. And they said that there was an existing IRS guidance from 2004 that prevents enrollees in high deductible health plans with HSAs from utilizing copay assistance. So essentially that guidance said if you have an HSA, then any copay assistance must be counted toward the deductible. So the FAQ argued that it was impossible to comply with both this guidance and the MBPP at the same time. So AIMED Alliance recently submitted a petition for rulemaking to the 3 agencies, arguing that IRS guidance is just that, it's guidance. It's not mandatory. It doesn't carry the weight of law, whereas the MBPP is a rule that went through the formal notice and rulemaking process, so it does carry the weight of law, and therefore it trumps the guidance or preempts it. However, we did hear back from the agencies. They reasserted that they were not going to be enforcing that MBPP due to stakeholder confusion. There is a Notice of Benefit and Payment Parameter for 2021 in the works. It's currently under review at the Office of Management and Budget, OMB, and we anticipate it being released any day now. So there are also some legal issues that we wanted to go over, and I do want to caveat this conversation by saying that this is a gray space because copay accumulators are pretty new in origin. There's a lack of existing precedent, so there are no cases, there's no case law currently in existence that have challenged copay accumulators. And legal analysis is highly dependent on a program's unique facts and structure. So just keep that in mind when we're going over these legal claims, because they're pretty hypothetical, but I do just want everybody to be aware of potential risks. So the first is, we created this, backing up a little, we created this report looking at key features of common copay accumulator policies, and that included policies that apply to all drugs, even the drugs that have no generic equivalent, using misleading or confusing language, using language that confer a benefit, and not disclosing the copay accumulator existence at all, or sometimes applying the copay accumulator program only to specific disease states. And based on some of those common trends, we found that some plans could be implementing copay accumulator policies in a way that violates the Affordable Care Act. The ACA has annual cost sharing limits. The maximum out-of-pocket limit is just under $8,000 for self-only plans and a little over $15,000 for family plans. And this limit applies to any employer-sponsored plan that chooses to offer coverage for essential health benefits. The ACA defines cost sharing as an expenditure which required by or on behalf of enrollees. So if a plan receives the full out-of-pocket amount from the plan enrollee and the full value of a coupon from a manufacturer, it could exceed that limit. Then there's the non-discrimination provision of the ACA. So some employer-sponsored plans may only apply their accumulators or maximizers to a specific list of conditions. We saw this at least once. They were only applying it to cancer, HIV, multiple sclerosis, and a couple other conditions. That could implicate the ACA's non-discrimination provision, at least for now. There is a pending rule that was put forth in HHS that might remove this protection from employer-sponsored plans. So employees wouldn't have to comply with it anymore. And it might also remove the private cause of action. So we definitely want to keep an eye on that. There's also the Federal Trade Commission Act. So under that, there's the unfair and deceptive act or practice protection. And that requires that plans not do anything that's misleading or deceptive. And failing to disclose or using misleading or confusing language could violate those protections, especially if it results in harm to the patient, both financially or harm in terms of an adverse event. And then there's ERISA, which also has the breach of duty not to disclose, breach of duty to disclose, and breach of duty not to mislead. So again, those plans that use misleading or confusing language or don't disclose the existence of copay accumulators could implicate ERISA as well. So we made several recommendations. They're intended to be really reasonable guardrails for copay accumulators. And the first one is, we recommend that if you're going to offer a high deductible health plan, also offer a traditional health plan. So if you have copay accumulators, it won't have as big of an impact if a person has a lower deductible. We also recommend complying with the notice of benefit and payment parameter, even if it isn't being enforced, and limiting copay accumulator programs to instances in which a generic is available and allowing for exceptions and appeals. We also recommend applying any assistance, copay assistance, towards that maximum out-of-pocket limit, even if it's not applied towards a deductible, so you're not violating the ACA. And then don't single out a specific disease or condition because that could be considered discriminatory. We recommend that you include consistent definitions and terminology, use plain language that makes it easy for plan enrollees to locate the plan language, and don't adopt these policies mid-year after employees are already locked into their plan. And we think that these are reasonable, moderate solutions, and they're important because you want your employees to be happy, healthy, and productive. And as John mentioned, if employees can't access their treatments, then these qualities could be compromised. And also, health benefits are great marketing and recruiting tools, whereas poor benefits can result in employee turnover. So with that, I'm going to turn it over to Rick Fry.
Thanks, Stacy. So real quick, I imagine many on the line may not be familiar with Trial Card, so I just want to give you a quick overview of what we do. So at Trial Card, we work on behalf of pharmaceutical manufacturers to provide access and affordability solutions to patients in order to help them get on and stay on the medicines that they're prescribed. So just wanted to let you know that, and that's kind of the lens that we're looking at this issue through, that being of our customers who are pharma manufacturers, but ultimately the patients that are on the receiving end of these assistance programs. So next slide. John did a really nice job explaining what accumulator adjustment programs are. I'll take a look at sort of what they look like operationally and how a patient may ultimately kind of find out that they're in a health plan with a copay accumulator program. We'll compare and contrast what it looks like with what we'll call traditional plan designs without a copay accumulator, and then followed by with a copay accumulator employed, and then our view of the stakeholder impacts of the various players that are involved in this. So next couple slides. So first, just a level set, we want to make sure everyone understands what we're talking about when we say a copay assistance program. Specifically, we're talking about programs that are funded by pharmaceutical manufacturers that pay for all or a portion of a commercially insured patient's out-of-pocket costs. Most often, and when we're talking about copay accumulator programs, we're talking about brand name drugs, specifically what you would categorize as specialty medications. So copay assistance programs pay for a patient's out-of-pocket costs, which may include deductibles, copayment, or co-insurance, depending on the health plan's design. What we're not talking about is something that you may be familiar with because companies like GoodRx in particular does direct-to-consumer marketing and TV commercials. These are what we call discount cards. So this is not what we're talking about here. We're talking about specific branded copay assistance programs. You can go to the next slide. So we'll look at briefly the process flow of how a patient, pharmacy, and health plan interact when it comes to a copay assistance program traditionally. And when I say traditionally, let's say pre-2017, before copay assistance or before copay accumulator programs really became more prevalent. So in this case, the patient takes their prescription, their copay card, and their insurance card to their pharmacy of choice, or this is sent to a specialty pharmacy, potentially over the phone. The pharmacy then bills the health plan's pharmacy benefit manager, their PBM. The PBM is going to respond back with a coverage determination, that being, is this a covered product where we're going to pay the claim or reject the claim for a non-covered drug or other reason. Assuming the product's covered, they'll also respond back with the patient's out-of-pocket responsibility. At that point in time, and traditionally how we have seen copay assistance programs work, is the health plan has no knowledge beyond that point as to how the patient pays for that remaining out-of-pocket cost. So now the pharmacy submits a secondary coordination of benefits claim to the copay program administrator, who processes that claim according to the program's business rules and responds back with any remaining patient out-of-pocket cost. The pharmacy then communicates to the patient their responsibility, any remaining cost, and dispenses the medication to the patient. The key thing here is that the patient receives credit towards their deductible and out-of-pocket maximum for their share of out-of-pocket expense that is actually funded by the copay assistance program. You can go to the next slide. So let's take a hypothetical scenario. In this case, we're going to have a drug that has a copay assistance program that's advertised as pay no more than $5 with up to $25,000 in annual benefit. We'll take a health plan design and we'll say that there's a $4,000 deductible followed by a $250 copay and a $6,000 individual out-of-pocket maximum. In this case, the drug cost, for easy math, we'll say is $10,000 a month. Go to the next slide. So here, to sort of orient you to the chart, month one, we'll call it January. The drug cost each month of $10,000. The patient cost share responsibility is the amount that the health plan is saying the patient needs to pay. So for month one, we have a $10,000 drug. The patient has a $4,000 deductible, followed by a $250 copay. This program is advertised as pay no more than $5, which means the patient is going to pay $5 and the manufacturer is going to pay the rest. So in this case, $4,245. The patient out-of-pocket accumulator is the amount that the health plan is crediting the patient towards their deductible and ultimately their max out-of-pocket. So in this case, the patient is getting credit for all $4,250 and the health plan is paying the remainder of that cost. In month two, we see that the patient is through their deductible, so now they only owe their $250 copay. The manufacturer program funds all but $5. And again, the patient gets credit for the full $250 that they were assigned as their out-of-pocket cost share responsibility. This repeats until we get to month 8, where ultimately the patient reaches their $6,000 out-of-pocket maximum. And then in month 9, now they've fully met their out-of-pocket maximum for the year of $6,000. At this point, the patient has no more out-of-pocket responsibility. The health plan is paying for the full cost of the drug, and the patient pays nothing. Also, the manufacturer copay assistance program pays nothing. One important assumption to take into consideration as I go through these examples is that these examples are purely in the context of one drug and the patient's out-of-pocket cost for that one drug. Where trial card sits, we're not able to know what other cost share responsibilities or medical expenses the patient may have that may play into them meeting their deductible or out-of-pocket cost. So this is just in the context of a hypothetical scenario where the patient is on one drug and that is their only healthcare cost. So we go to the next slide now, and we'll look at how this differs in a health plan design where there's a copay accumulator program in play. Go to the next slide. So the process flow here looks basically the same. The key difference is that, go back one, I'm sorry. The key difference here is that whereas in the first scenario, when the health plan, the PBM pays the claim, they don't have any knowledge of any downstream payers or secondary claims. In this case, the health plan does have knowledge that the patient is going to be using a copay assistance program. So when that health plan responds back with the out-of-pocket cost, they know that not all of that money that the patient owes is going to get credited towards their deductible and out-of-pocket costs for the year. So we can go to the next slide. So this is the same example again, about $10,000 a month drug. The patient has a $4,000 deductible, followed by $250 copay. In this case, again, in month one, it looks about the same. The manufacturer is going to pay for all but $5. But the difference here is the patient out-of-pocket accumulator amount that the health plan is crediting the patient. In this case, the patient only gets credit for the $5 that they paid, and no credit is given for the cost share funded by the copay assistance program. In month two, we see the same pattern repeated. Again, the patient only gets credit for the $5, and their out-of-pocket accumulator is only credited $5. This continues until we get to month 6 and month 7 in what we kind of call the copay surprise. So what's important to think about here is how your employees or the plan beneficiaries are going to react to this. In a lot of cases, patients may have been on this drug and using this copay assistance program for a couple of years, and they've become accustomed to how it works and become accustomed to, in this case, paying $5. But now they get to a certain point in the year where the program funds are exhausted. They've reached their $25,000 program benefit limit, and in month 6, all of a sudden they owe $475. This is where the trial card starts to see the real patient impact, because now the patient is confused, unaware, and at this point severely at risk to discontinuing their medication and stopping therapy. But let's assume they pay the $475, and that gets credited towards their out-of-pocket amount, towards their deductible. Then in month 7, they come back, and here's where the patient is faced with even a higher cost share burden because they haven't quite reached their deductible yet. So now the patient is forced to pay $3,775. At this point, they're significantly at risk of discontinuing that medication and stopping therapy. If they were to proceed through, pay through their deductible and get to their copay, they would get through the year, and you'll see that ultimately the patient's going to pay more out of their own pocket. The manufacturer is going to pay the full $25,000 that they offer, and the health plan will pay a little bit less in this case. We can go to the next slide and look at that comparison. So the traditional plan design row, that's where the manufacturer program, that funding is getting credited towards the patient out of pocket. And the big difference here is the ultimate patient cost share responsibility. The traditional plan is $6,000, which is what we would expect to see based on their maximum out of pocket. Whereas with the copay accumulator adjuster employed, the patient cost share, the health plan of the PBM is actually assigned over $30,000 to the patient, which most of that is then paid by the manufacturer's copay assistance program. On the flip side, the health plan cost, at least in the context of this one prescription drug, is reduced by nearly $25,000. You know, the next slide. So now we'll take a look at what's in it for sort of the key stakeholders, and we'll talk about first PBMs. So pharmacy benefit managers. we first started seeing these become more prevalent again in about 2017. Some existed prior to that. But what it amounts to is a new service offering for their health plan customers. As advertised, it gives them the ability to offer specialty drug cost savings or cost avoidance for the plan sponsors. And through doing this, it's an additional source of revenue for the PBMs. Next, health plan sponsors. And our assumption here, of course, is that the health plan sponsors are doing this to lower their prescription drug spend by taking advantage of the manufacturer copay assistance programs and forcing patients to pay through their deductible and max out-of-pocket. For specialty pharmacies, first, kind of maybe a positive. The way these programs are operationalized is through data sharing between the specialty pharmacy and the pharmacy benefit manager. So in many cases, patients are forced into one of a few specialty pharmacies or most likely the SP that is wholly owned by the PBM. So that may pull additional patients into that pharmacy. On the flip side, the pharmacy may actually be at risk of losing patients if and when they discontinue therapy due to that copay surprise and that high out-of-pocket cost. And then lastly, for trial card, of course, we speak with our customers about this frequently. And what does it mean for manufacturers? Increasing costs to provide these assistance programs that patients need. Their return on investment in these programs will suffer. And then ultimately, if patients discontinue and abandon therapy, that's lost revenue for the manufacturer if they no longer are taking that prescription. But there's one key stakeholder that we've notably left out, and that's the patient. So patients are, in our experience, very unaware that these programs are in operation and are kind of left out in the cold, wondering what to do next. So that first point, patients see confusion, which quickly leads to stress and not understanding what to do when their program benefits run out. At that point, there's been many studies published about the relationship between both deductibles and just any out-of-pocket cost and patient adherence, so that higher risk of discontinuing therapy. That may lead to further negative health outcomes due to stopping that drug. Dissatisfaction with their health plan. One of my favorite terms, because it's just so descriptive, is financial toxicity, and I'm sure everyone's seen reports of various forms of bankruptcy and things like that due to high medical costs, and this may contribute to that. And lastly, kind of in line with how these programs may be operated, is families with hereditary conditions such as hemophilia may be hit the hardest. There may be several members in a family that rely on a similar program due to their condition. Go to the next slide. So some recommendations, very much in line with what we've discussed to this point. It's really important to provide educational sessions and clear descriptions of what the health plan, what the prescription drug benefit is doing for patients, so that patients can, and your employees can very clearly know what they're signing up for and what that means to them. If you choose to offer a plan with a copay accumulator, implement it in such a way as you might avoid the copay surprise. These copay accumulators come in various forms. One that you may hear the term maximizer. And what a maximizer variant of this does is actually takes the manufacturer assistance program and usually evenly distributes what's available in that program over the full 12 months. The benefit there is the cost savings of gaining all that those manufacturer dollars is still available, but the patient isn't left on the hook with a copay at any point in the year because those cost share responsibility is distributed evenly over the course of 12 months. And then lastly, we like to say, consider the total cost of ownership of your insurance benefits and what that means to the patient in the broader context of their overall health and productivity. So the medical costs that may ensue if a patient were to have negative outcomes, lost productivity, employee morale, and job satisfaction. And finally, we'll just leave you with a couple quotes that we've come across at the first meeting from a blog post not too long ago. The problem is that copay accumulator programs will lower a plan's drug spending by discouraging the appropriate utilization of specialty therapies and reducing adherence. And second, from our CEO, patients are not choosing expensive brand name drugs over cheaper generics. They're choosing expensive drugs over no drugs. And that goes back to where these copay accumulators are employed, that being with specialty products. The vast majority of the specialty products that are on the market that patients are taking for complex conditions do not have generic equivalents. So there's not an opportunity to switch the patient to a lower cost alternative. And that's where I'll wrap up, and we'll turn it over to Bruce Sherman.
Thanks, Rick. Now we're going to, with this background in here, now we're going to talk about some real-world experience with respect to implementation of copay accumulator adjustment programs. If we go to the next slide, you've heard John and Rick both talk about the role of copay cards from the employer perspective, that perhaps those self-insured employers see the copay cards circumventing plan design, that the employees have made a specific choice for the high deductible HSA plan where these the copay accumulator adjustment programs are operationalized, and if people have signed up for those plans, then they should be aware of the implications that they have to reach their deductible before the plan contributes. And then lastly is comment about a woman going into the hospital for a routine delivery. Deductible is paid in that setting. There is no copay card, so why should there be a copay assistance for medications? But the issue with the copay accumulator adjustment cards is that while as many as 1/3 to perhaps up to half of employers either are offering these or are considering offering them, is that these programs have been implemented without a lot of data. And working in the setting of a company where a copay accumulator adjustment program was implemented in 2017, we thought it would be reasonable to take a critical look and see exactly what's happening. A lot of conjecture about the potential implications for implementing the copay accumulator adjustment program, but what the actual data tell us. So if we go to the next slide, as I shared with you, the copay accumulator adjustment program was implemented in 2017. Before that time, there was no program. We looked at individuals that were prescribed specialty meds for treatment of autoimmune conditions. So we zeroed in on that population, since those are the individuals who are likely to be taking specialty medications over a prolonged period of time. And what you see on this slide, comparing the PPO enrollees to the HSA enrollees, that in 2016 the adherence rates, which is essentially what we're looking at in these slides, seem reasonably parallel for both the HSA enrollees and the PPO enrollees. But when we look at 2017, what we see is that the HSA adherence, or the proportion of individuals continuing to take their medications, drops off over time relative to those individuals that are enrolled in the PPO plan. And what this suggests to us, as you have heard from Rick, is that individuals experiencing that so-called copay surprise may well be stopping their medications because of that copay surprise and the out-of-pocket cost exposure. When we look at the next slide, what we see is that, in fact, the proportion of individuals who discontinued their medications after the implementation of the copay accumulator adjuster program was fourfold higher. Almost 30% of people stopped their medications after the copay accumulator adjustment program was implemented. Now we know that based on some national data, 40% of people can't pay for an unexpected $400 expense. So when you see Rick's data indicating that this copay surprise could be literally thousands of dollars, is it any wonder that we are seeing this type of discontinuation rate? Now we wanted to check and see, if we go to the next slide, we wanted to check and see whether this was a legitimate or a bona fide phenomenon. So we compared the autoimmune medication results, looking at medication discontinuation, with those individuals with multiple sclerosis who are taking medications that were included on the preventive drug list. Now, for individuals with medications on the preventive drug list, these are essentially pre-deductible medications, meaning that patients don't have to satisfy the deductible. They may have a nominal copayment to make for receipt of the prescription, but they don't have that large deductible that individuals have in receiving autoimmune drugs in an HSA plan. And what you see in this slide, and this is sort of our sensitivity analysis, if you will, is that individuals who had multiple sclerosis where the medications were on that preventive drug list had similar medication discontinuation rates, whether they were in the PPO or the HSA plan. Contrast to what we saw on the prior slide, again depicted here, is that individuals taking autoimmune medications that were subject to the Copay Accumulator Adjuster program, substantial medication discontinuation relative to individuals in the PPO plan. So our impression or our conclusion based on those findings was that the Copay Accumulator Adjuster program had a substantial impact on medication discontinuation. Now, if we go to the next slide, you can see that this is data that I think reflects that from both John and Rick's comments about the effect of maintained compliance or increased compliance with medication for specialty drugs on overall medical costs. And what you can see here is that the first bar on the left-hand side, if there is a 10% increase in medication use, PDC stands for proportion of days covered, meaning that people have 10% more days when they have medication available to them, that yes, healthcare costs or medical costs are going to go up, and that's for the specialty medications. But when we look at the cost for other drugs and the cost for medical care, we see those decreasing. The net result is a $101 reduction in overall costs because the increase in specialty RX costs is more than offset by a reduction in medical care and other prescription drug use. So there is a case to be made that the converse of this is true, in that if people reduce their use of specialty medications, that overall healthcare costs may indeed increase because of suboptimal disease control. If we go to the next slide, again, just reiterating some of the study conclusions, we saw that individuals who were enrolled in high-deductible health plans that were subject to copay accumulator adjustment programs had a higher risk of discontinuation, a lower proportion of days covered, and that medications that were on the preventive drug list, in this case, medications for treatment of multiple sclerosis, were not impacted by the copay accumulator adjustment program. So our conclusion, as I've stated, was that these copay accumulator adjustment programs have the potential to negatively affect specialty drug use. What we didn't do, and we are in the process of a much more substantial analysis, is actually looking at overall medical expenditures as a consequence of implementation of the copay accumulator adjustment programs. To our knowledge, this kind of analysis has yet to be completed, and we're hopefully going to do this with a number of jumbo employers so that we can truly see what the overall healthcare cost implication is for implementation of copay accumulator adjustment programs. The one key implication, and I think you've heard about the financial barriers already, is the issue of what happens to low-wage workers. In some other research that we've performed, we see substantial price sensitivity of low-wage workers to increases in healthcare costs, meaning that if costs increase, people use less or fewer healthcare services, including they're less adherent to prescription medications. This is more substantially impacting low-income individuals who have less financial reserves and may have to make a choice of food on the table or paying for medications. So it's important to think about this subpopulation, and it's one of the areas of study that we feel is particularly important. Employer benefits personnel typically design benefits for people like them and don't often think about the cost implications for low-income individuals. To that end, it's clear that we have opportunities to think about benefit designs perhaps a bit more creatively to try to preserve this balance of ensuring that people have appropriate access to medications while not breaking the benefits bank, so to speak. And on the next slide, I have some suggestions for you with respect to employers who may be either offering or thinking about offering a copay accumulator adjustment program. Firstly, make sure that there are multiple plan options available. We've seen a trend away from high deductible health plans as a sole option, and for individuals that may be facing high copay costs for specialty drugs in the setting of a high deductible health plan, it's great that they understand the cost implications of the high deductible plan compared with the PPO. If you have a copay accumulator program, then ensure that the copay assistance that is received is applied to the plan's cost sharing limits, meaning that let the individual derive the benefit from the copay assistance that they receive. I think one of the critical points we need to make here is that patients don't want to be taking these medications. Many of them are either injectables or infusibles are associated with patient discomfort. People aren't going to want to be taking these medications just because they can't. They're taking them because they have a medical issue that derives benefit from treatment with specialty drugs. We've already heard my colleagues talk about singling out or not to single out specific disease states because that could be construed as discriminatory. Again, this issue on the right-hand side of the slide, if there is no lower-cost generic alternative, then perhaps the Copay Accumulator Adjuster program should not be implemented in that setting. From a descriptor standpoint, it is critical that, as we've heard as well previously, plain language descriptions of the program and the implications. I would hope that if employers have benefits modeling tools, that these kinds of that Copay Accumulator Adjuster programs are built into the benefits planning, and they aren't, unfortunately, always done. And then the last thing is there may be, as I mentioned before, this issue of a wage implication in relation to how individuals in different wage classes are impacted by out-of-pocket expenditures particularly related to the Copay Accumulator Adjuster program. And it may be that there is a way to redesign benefits to make them more equitable, such that earners of lower incomes in your workforces actually have subsidies that help to offset the Copay Accumulator Adjuster programs relative to higher income individuals who may well be able to afford the cost implication of the Copay Accumulator Adjuster programs. So just some ideas here. Hopefully you'll find these of value. We can move on to the next slide. Happy to now transition over to address some of the questions. I appreciate that we've had a number come in through the Q&A portion of the website. Kimberly?
Yes, thank you, Dr. Sherman. So yeah, I just want to take some questions now, and as a reminder, you can still submit questions. You can go ahead and do that through the Q&A the panel, and then it looks like we might have some in the chat too, so I'll try to get to those as well. We also want to thank our sponsors, but let's go ahead and look at some of those questions. So the first one was, if I have a 16-digit copay card from industry and I am receiving shipping medications from a specialty pharmacy, how would a plan identify the card as industry funded and accumulate? I think that question's for Rick.
Yeah, so that's a really good question. So the answer is it probably depends. So in most cases, the specialty pharmacy probably will not know that that's a manufacturer funded card. The way most copay accumulator programs work is when it is a pharmacy benefit or pharmacy claim copay card. So there's a BIN number, PCN group number, and it's submitted through the pharmacy claim system, just like an insurance claim would be. A debit card provides less visibility to the specialty pharmacy and the PBM to know that it's manufacturer funded.
Great, thank you. It looks like the next question is, at least in Virginia, prior to the law's passage, any financial assistance was not counted, even if it was not from a pharmaceutical company, i.e., if I paid for my daughter's meds. How many companies are continuing to consider these types of financial assistance as not counting towards the out-of-pocket amount? Does anybody want to take that question?
Yeah, this is Bruce. I can jump in here. It's intriguing to me. I've heard of companies that are actually asking employees to sign attestations that they have not received any subsidies in their payment for services when enrolled in a high deductible health plan. And that to me seems a bit draconian, if you will. We understand the importance of employers wanting employees to bear responsibility, the financial responsibility for the plan for which they signed up. But I think we're seeing pushback from employees that affordability concerns are widespread and quite common. And as a result, we're seeing, I think, a shift away from this kind of approach. One thing I will add is that we were told when doing this research, we were in contact with the PBM from which we were provided these data for our study. We said, what happens if people discontinue their medications? And we were told that the PBMs actually reach out to the patient when they note the medication discontinuation and try to get them connected to means-based resources to provide financial support when the patients truly can't afford the medication. So whether it's a free drug resource, whether it's means-based subsidies or support from the pharma manufacturer or other channels, that seems to be permissible. The biggest issue from the PBM's perspective is that there should be a financial need to warrant pursuit of these kinds of alternative financial resources. The challenge is that although the PBM said that they were doing those things, we saw the data that I presented to you showing that even with the PBM's effort at connecting individuals with available resources to provide some subsidies in the face of a copay accumulator adjustment program, we're still seeing a lot of people discontinue their medications. So that approach as a plan B, if you will, doesn't seem to be working all that well.
Great, thank you. So it looks like the next question is, what is the difference to the patient employee between a copay assistance program and a discount card, as long as the patient employee gets to pay less for their prescription?
So this is Rick, I can take that one. The biggest difference is with a manufacturer-sponsored copay assistance program, the manufacturer is an additional third-party payer, so they're actually contributing funds to the cost of that drug. With a discount card program like a GoodRx, there is no additional payer involved. So that is submitted as a primary claim to the discount card company, and the patient at that point is the only payer involved. Typically, the cash discount cards are used more for generic medications, whereas the manufacturer programs are for branded medications. And a discount card may come into play when a patient is either truly uninsured, has no form of insurance benefits, and what a discount card does is provide them the benefit of a GoodRx's negotiating power to get a lower price at the pharmacy counter rather than paying the pharmacy's cash price. It also may make sense for patients when the patient is in their deductible in some cases as well.
Great, thank you. I think this next question is for you as well. It talks about one of your examples. It said, your example shows the insurer saving $24K, but did you leave out that they also collect $25K from copay cards, so they were paid twice and therefore came out almost $50K ahead?
So at a high level, what the accumulator adjustment program is doing is taking all of the manufacturer funds, not counting it towards the patient's deductible or max out-of-pocket. So you can kind of consider that $25,000 right off the bat that the employer benefits from. In addition to that would be more of a cost avoidance in the sense that assuming the patient stays on therapy, they're going to pay through their deductible and up to their max out-of-pocket. So that's allowing the patient to pay what the plan design says they should pay. So it's not really a double to get to $50,000. It's getting the patient to pay actually out of their own pocket or their deductible, and then the manufacturer program contributing all the funds that are available in that program.
Thank you. Then the last question is, why should a plan apply the copay assistance that is received to accumulators? This would essentially allow the participant to receive insurance benefits for expenses they have not paid. How is that fair to the plan sponsor? Does anybody want to take that?
Yeah, this is Bruce. I'll address the issue. This is the dilemma. This is the perspective from many employers who feel that copay assistance cards are circumventing the benefit design for which the employee has signed up. And that's not fair to the plan sponsor. So operationally, they've implemented the copay accumulator adjuster programs to counter the copay assistance, if you will, from the patient. This is the challenge of finding the balance between what plan design individuals receiving specialty medications should be enrolled, and how employers can balance out equitable support for those individuals who need to take expensive medications. It's not an easy answer. Employers need to make the decision themselves. As part of our analysis, we actually looked at the implications for the employer if they were to cover the amount that the copay accumulator adjuster program was essentially forcing the patients to pay out of pocket if they wanted to continue their medications. And it was about a penny per member per month. So we're not talking about a lot of money. And the dilemma becomes, do employers do the right thing and ensure that their employees have affordable access to care, or stand by the plan sponsor benefit design and ensure that people adhere to the explicit details of the plan design.
Thank you. It looks like we're out of time right now. I know there are still a couple more questions left. I would suggest that if you have a question that has not been answered, email it to us, and we're happy to get you those answers. You can email it us at policy@aimedalliance.org. And I want to just thank our speakers today. You've all been really wonderful and provided some great insight, as well as thank you to our sponsors, AbbVie and Bio. And with that, we'll conclude our presentation, and everybody have a wonderful day.
I'd like to thank our presenters as well as all of you for joining us today. If you'd like to view this webcast again, the archive recording will be available on the hr.com website within 24 hours. The webcast credit will show on your hr.com account within 2 business days, and we'll also send you an email with your credit information. Your feedback is important to us. Please take a moment to fill out the exit survey that opened in a new browser page on your computer. This concludes our webcast. Enjoy the rest of your day.